or right ventricular failure, to be honest, we don't know, or I don't know. We know very well the risk factors. We know how to treat an acute cardiopulmonale from a respiratory strategy point of view, and especially I will show you some slides about proning. But there is no data supporting that when you systematically apply a right ventricular protective approach, you could prevent the occurrence of right ventricular failure or acute cardiopulmonale, and so improve prognosis. So Armand show you this study published for the 50th birthday of ARDS. And just there is some redundancy, but you know that the risk factors, pneumonia, driving pressure higher than 18, PONF ratio lower than 150, PSCO2 higher than 48 millimeters of mercury. And you recognize what Armand showed you. This is the incidence of ACP according to the different number of risk factors. And the key point is that what you may modify on the respirator if you want to, let's say, prevent or at least to treat the acute cardiopulmonale. And the first factors that you may modify regards pressures. And you know there is a driving pressure, there is the transpulmonary pressure, there is a mean airway pressure, there is a plateau pressure. And I want to briefly summarize some points on these different pressure. First, I want to show you this case, for instance, in patient ventilated for ARDS. And you can see that along the worsening of the ARDS, you may observe an increase in the plateau pressure and in the driving pressure. This is after 1 day under mechanical ventilation, no norepinephrine. After 2 days, you can see that the right ventricle is much bigger and the patient requires a slight dose of norepinephrine infusions. And after 3 days, you can see now how is big the right ventricle and how is completely compressed the left ventricle. And you can see a high dose of norepinephrine infusion. So plateau pressure and driving pressure in this situation. At the opposite, you may sometimes observe in this kind of patient with a high plateau pressure and high driving pressure that the systolic atrial pressure is low, the heart rate is high. You see that the right ventricle is dilated and there is some paradoxical septal motion. And you may propose to modify the pressure on the ventilator by decreasing the tidal volume. You decrease the plateau pressure and the driving pressure. You improve the hemodynamics, so the systolic atrial pressure and the heart rate. And you may check for the right ventricular function. And you can see now that the right ventricle is much lower dilated. And there is still some paradoxical septal motion, but the situation seems much better than the previous one. And so clearly, the main advantage of the plateau pressure is that this is something that you may directly monitor on the respirator. You have no calculation to do, plateau pressure minus a total PEEP, for instance, to have the driving pressure. And we reported in this study a few years ago the incidence and the mortality of ACP and the mortality according to different ranges of plateau pressure. And you can see that providing that the plateau pressure was maintained below 27 centimeters of water, the incidence of ACP and the mortality of patients were very low. The transpulmonary pressure, we have more and more studies now, but the big point is that you need to monitor and to measure the esophageal pressure to calculate the transpulmonary pressure. Something difficult to do in clinical practice, but something very valuable to see the effect of respiratory settings on right ventricular function. Look at this study in ARDS, low tidal volume, moderate tidal volume, very high tidal volume. You recognize the airway pressure trace, the esophageal pressure, and this patient had a pulmonary artery catheter, so you see the pulmonary artery pressure and the right ventricular pressure. So with the low tidal volume, the transpulmonary pressure at inspiration is moderately elevated. With the moderate tidal volume, this is increased. And with the high tidal volume, this is very significantly increased. What is the consequence in terms of right ventricular function? You have here, between the two arrows, this is the pressure between the closing of the tricuspid valve and the opening of the pulmonary valve. So this is the isovolumetric contraction pressure. This is that the pressure that the right ventricle has to generate to open the pulmonary valve and to eject blood into the pulmonary circulation. So something very related to the right ventricular afterload. So you see during expiration, 9, during inspiration, 11 with the low tidal volume, 14 with the moderate tidal volume, 17 with the high tidal volume. And look at also the pulse pressure, not on the systemic part, but on the pulmonary part. This is the differential between the systolic pulmonary artery pressure and the diastolic pulmonary artery pressure, reflecting the right ventricular stroke volume. You can see with the low tidal volume that the pulse pressure is not so low. And look at with the high tidal volume how is low the pulse pressure. So the right ventricular stroke volume is completely decreased during inspiration when you apply this high tidal volume and if you generate the high transpulmonary pressure. And if you look at some studies, I just show you this one because I know that Alain was the one of the moderator, and this is a severe ARDS on ECMO. But you know that they are on ECMO, but they are still ventilated. And you can see when they spontaneously breathe, they may generate high level of transpulmonary pressure. This is PL, and you can see at least the maximal level in pressure support in this study was 38 centimeters of water. So for very, very high level of transpulmonary pressure with probably some deleterious effect on the pulmonary circulation and the right ventricle. The mean airway pressure. The mean airway pressure is interesting, something difficult to monitor and to calculate at the bedside in clinical practice, but something probably deleterious for the pulmonary circulation and the right ventricle. Look at this study performed by the team from Marseille, and this is a study comparing the volume control mode to the HFO ventilation. And that's interesting because there are different respiratory settings for the HFO regarding the level of the mean airway pressure which is applied to the patient. And you can see that they calculated the mean airway pressure in volume control mode, and they decided to ventilate the patient with HFO with a mean airway pressure +5, +10, or +15 centimeters of water compared to the baseline in volume control mode. And what are the effects on the right ventricular function? You have the effect here. In white, the right ventricular dysfunction. In gray, the right ventricular failure. And you can see that if you compare the different respiratory settings of HFO to the control mode ventilation, you can see volume control ventilation. You can see that you increase the incidence of right ventricular dysfunction and also failure. But what is important, this is especially occur in the respiratory settings when the mean airway pressure is very, very significantly elevated. I mean +15 centimeters of water compared to the baseline. You have also other factors that you may modify and that may act on the pulmonary circulation and the right ventricle. This is the PaO2, the blood gas, of course, PaO2, PaCO2, and pH. So very briefly, as you know, there is a vasoconstriction of the pulmonary circulation, which is related to the level of hypoxemia, but also to the level of hypercapnia. Both are acting on the pulmonary circulation to increase the pulmonary artery pressure. And this is a very old study, and you have the relationship between the pulmonary artery pressure, the mean pulmonary artery pressure, and the oxygen unsaturation. And you can see that when there is at least no acidosis or even alkalosis, when you increase the oxygen unsaturation, there is at least no increase in mean pulmonary artery pressure. But you can see that when you associate oxygen unsaturation with acidosis, which could be respiratory acidosis, you can see now that when you increase a little bit the level of hypoxemia, you increase a lot the level of mean pulmonary artery pressure, which is generated. So you induce increased right ventricular afterload, and probably you may induce some right ventricular failure. And this is something very interesting, and we start to have a few data, a few studies. This is a study performed in animals regarding CO2 removal. And this is a model of surfactant depletion in animals. And you can see the PaO2 and the PaCO2 and the pH at baseline after the occurrence of ARDS, during CO2 removal, and after stopping the CO2 removal device. And you can see that when you remove the PSCO2, you can see that the PSCO2 is able to decrease, but in the same time you increase the oxygenation. This is always the case. When you decrease a little bit the PSCO2, not a little bit, but from 80 millimeters of mercury to 40, you significantly increase also the oxygenation. You can see that in terms of right ventricular function and the EES on EA, this is the coupling of the pulmonary, right ventricular pulmonary circulation, so the effectiveness of the right ventricle. And you can see that the normal right ventricular function, the coupling is around 1. So you can see at baseline this is 1. During ARDS, this decreases a lot, 0.5, so a huge decrease in right ventricular function, in right ventricular coupling. And you can see just by removing CO2, you can see an improvement, a significant improvement in right ventricular function, which decrease, which is also altered when you stop the CO2 removal. And this is the variation of the systolic pulmonary arterial pressure along the design of the study. During ARDS, pulmonary hypertension. During CO2 removal, decrease in pulmonary pressure. And after stopping the CO2 removal, you induce again some pulmonary hypertension. And this is something that you may observe using echo. You can see here this patient with ARDS. At day 1, the PSCO2 is very high. The base deficit is very high, so there is also some metabolic acidosis because this patient was in shock. And you can see after optimization of the respiratory settings and also after resuscitation of the patient, you can see that the PSCO2 was much lower, the base deficit was at least corrected, and you can see that the right ventricle is much less dilated than at baseline. This is the paper that Armand showed you regarding the comparison of 3 times PSCO2 in 50 millimeters of mercury, one time with different respiratory setting where the PSCO2 was increased, 71, and the second one, 75. You can see that the pH significantly decreased, and you may observe that the right ventricle dilated significantly after applying a high PSCO2. Look at here with the low PSCO2 or permissive hypercapnia in a correct range. You can see no paradoxical septal motion. And you can see after an hour and a half of high PSCO2, you can see right ventricular dilatation and paradoxical septal motion. So this is something that you have to do to treat and maybe to prevent, we don't know, the right ventricular failure, which is the prone positioning. Look at this study that we published in Chest in 2007. You can see before the proning and after a session of 18 hours of proning, you have patients group 1 with acute cor pulmonale, and you can see after the proning the decrease in the right ventricular size and the increase in the left ventricular size. So you improve a lot the hemodynamics and especially the right ventricular function. And this is especially because when you turn prone the patient, actually you improve the P-on-F ratio, you decrease the PSCO2, and you decrease the plateau pressure because you recruit the lung and you increase the lung compliance. So you act on most of the factors that you may act to improve the right ventricular function. And it may explain, maybe yes, maybe not, the beneficial effect that was reported in the PROSEVA study. And if you look at, especially in the PROSEVA studies, the different respiratory settings, you can see that the PEEP was lower than 10. The plateau pressure was around 22. The driving pressure was lower than 13. And the PSCO2 was maintained around 45 millimeters of mercury, which is a very nice right ventricular protective approach. And if you look at in the supplementary data of this paper regarding the cardiovascular failure, you can see in the proning group that the patient had lower cardiovascular failure compared to the supine group. So, like as the proning was able to support the hemodynamics of this patient. And this is especially true, but probably another issue, that they observed less cardiac arrest in the prone positioning group compared to the supine group.